So welcome everyone. Thank you for being here tonight. Today we will be setting up a webinar on understanding pregnancy and fertility in IBD. So my name is Rashane, and I am the Manager of Research Grants, Impact Communication and Evaluation at Crohn's and Colitis Canada, and I will be the moderator for tonight's event. Before we kick things off, let's go over some technical updates and technical details. So this session is offered both in English and French. To access either language, please select interpretation in the menu bar below and choose the language of your choice. If you wish to see the slides in English or French, please click the tab at the top of your screen labeled English or French. If you encounter any technical issues, try refreshing your browser or rejoining the webinar. Alternatively, share your concerns in the Q&A box and we will try our best to assist you throughout the webinar. Next, I'd like to acknowledge the rich history and heritage of Canada's Indigenous people. While we meet today on a virtual platform, we recognize the importance of the lands which we call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that call this land home. Through this acknowledgement, we convey our respect for the traditional territories and Indigenous communities and contribute to the promotion of reconciliation. Next, I'd like to issue a quick disclaimer. The content in this presentation by Crohn's and Colitis Canada is intended solely for educational purposes. While the information holds general value, it may not be applicable to specific medical situations. Online resources should not be seen as a substitute for personalized judgment or care provided by a trained healthcare professional. Crohn's and Colitis Canada does not endorse any external product or service mentioned during the webinar. So for those of you joining us for the first time, allow me to share Crohn's and Colitis Canada's commitment with you today. Our organization is dedicated to discovering a cure for Crohn's disease and ulcerative colitis. Through research, education, awareness, and advocacy, our organization strives to enhance the lives of everyone affected by these chronic diseases. I also wanted to plug some of the programs and services that are available at Crohn's and Colitis Canada. If you or someone you know is living with Crohn's disease or ulcerative colitis, we invite you to explore our Crohn's and Colitis Connect platform. This is an online community that offers the opportunity for individuals with IBD to engage with one another and talk about the challenges that come with living with IBD, and it's a safe space to seek advice and understanding. You can also find details about upcoming events listed here on the screen by either visiting our website or scanning the QR code. We're excited to share that peer support events in English are coming up soon on October 7th and 8th. And for our French-speaking community, a dedicated French language event will take place on November 18th. We encourage you to join and connect with others who understand the journey of living with IBD. Next, we'll proceed to the first portion of our talk, which is a short presentation by our lived experience partner, Laura. So before she begins, I'm just going to give a very quick introduction. She'll talk more about her experience. So Laura was diagnosed with IBD in 2000, which inspired her to become a registered nurse. She's also a proud mom of 3 kids and her dog. And she also shares her adventure with her partner who also has Crohn's. And when I asked her for her bio, she said, "Nothing says true love like matching unpredictable intestines," which I thought was super cute. She's a coffee lover and a passionate advocate, and she will be sharing her personal experience with pregnancy as a woman living with IBD. On a personal note, I wanted to share that I've had a few conversations with Laura before this as we were preparing for this webinar, and I have to say she's an incredibly thoughtful and kind individual. She supports Crohn's and Colitis Canada in numerous ways, the biggest being she is a peer mentor and a volunteer moderator on the Crohn's and Colitis Connect platform. Together, I must say the CCC team is deeply grateful for her time and her openness to help the IBD community. So thank you, Laura, and please take it away.
Alrighty. Okay, perfect. So welcome. I was thrilled when I was asked to share my story on this topic. It's my sincere hope that my story will resonate with some of you and it may empower you to ask questions and make informed decisions. Tonight, you'll hear me share some deeply personal stories. My story is mine alone to tell. It is by no way indicative of every pregnancy with IBD, but it is what happened to me. Without further ado, let's start at the beginning. You can switch the slides, please. We look so young. So on our first date, we immediately hit things off. After sharing with each other that we both have Crohn's, I knew I was going to marry him. 2 years later, we were walking down the aisle. We were in our late 20s and we knew that we wanted kids right away. So we met with our gastroenterologist to talk about next steps. So please keep in mind this was 13 years ago and treatments and knowledge have evolved since then. Both my husband and I were taking a drug called 6-NP, 6-mercaptopurine. I trialed going off of it before the wedding, but landed in a hospital, back on prednisone, and was told to continue the 6-NP. My Asacol was also switched to Pentasa as the coating was thought to possibly be harmful to the baby. Between medications my husband was on and my mildly active Crohn's disease, we were told it may be very difficult to get pregnant. But surprise, next slide, please. Do my little dance while they're switching slides.
Oh, I've switched my slides. I think there's a slight delay.
Oh, there we go. Okay, perfect. Surprise wedding night, baby. So we traveled to Germany on our honeymoon. I was about 2 months pregnant at that time. My Crohn's flared up the worst it has ever been in my life. Everything I ate came immediately out of me, whether through diarrhea or vomiting, which I was doing several times a day. One fateful night, we were taking an overnight train to Berlin. I spent the entire time alone in the bathroom. I had incredibly bad abdominal pain and there was blood everywhere. I was worried I was miscarrying as there was just so much blood and I was in so much pain, I couldn't figure out where it was all coming from. I ended up in the hospital in both Berlin and Munich during that trip. Thankfully, baby was fine, and we got our first look on ultrasound of our little baby Jay. Both hospitals admitted me for fluid resuscitation, as well as starting me on rectal prednisone. So try explaining that one when you go through customs. Things settled a bit when I returned to Canada, although I continued to vomit daily. I was followed by high-risk OB. When I inquired about Declectin, a drug that would normally help nausea and vomiting in pregnancy, I was informed that they had no idea what its effect to IBD would be, and thus I was denied the medication. As I couldn't function, the vomiting was so bad, I was continuously taking low doses of gravel. At 29 weeks, things took an unexpected and life-threatening turn. Switch, please. At 29 weeks, I became extremely itchy. When I mean extremely, I have permanent scars all over my body, attesting to how hard I scratched. The itching was predominantly the palms of my hands and the soles of my feet. The doctors and nurses I worked with were also commenting that I looked awful. The sclera, the white part of my eye, had taken on a yellow hue. I had zero energy and the vomiting had increased as well. When I met with OB, I was given a pamphlet on vomiting in pregnancy and told to eat small meals like crackers. Had I been asked about it, I would have reported pasty stools and tea-colored urine. But I was never asked, and I didn't know enough to volunteer that information. I was given a blood rec and told by the doctor to complete sometime that week. Upon leaving the clinic, the nurse pulled me aside and encouraged me to do it stat and to keep my phone nearby. She never did have a chance to call me as I went into labor at work that afternoon. There was again blood everywhere, diarrhea, and horrible abdominal pain. Sounds a lot like Crohn's, right? At the hospital, I naively told the staff, maybe I should call work and let them know that I might need the day off. Their response, you won't be going back to work, at least not for another year. You're 2 centimeters dilated, 100% effaced. Your baby is coming now. Switch, please. I'm a numbers person, and for all you health professionals out there, my bilirubin was over 200, AST, ALT were over 400. For non-medical people, my liver was not doing well. After 5 days, yes, you heard that right, 5 days of active labor, I was told every extra hour counted. It would give the baby a chance to work and a better chance of survival. I wasn't allowed to walk around, sit in a bath, or what I had always envisioned labor to be about. The NICU staff did a good job preparing us to what delivery would be like. Our baby would be born blue. He would be immediately carried away to be intubated, so a tube stuck down his throat to help him breathe. And there would definitely be no newborn baby cry. Boy, they were wrong. I will never forget the most beautiful high-pitched cry that came from my 3-pound son. My husband even got to cut the cord. He spent 31 days in the neonatal ICU. He was discharged at exactly 35 weeks gestation, the youngest a baby can return home. Switch, please. My path was not so easy. Remember, I have Crohn's, that's why you're listening to me, right? From years of prednisone use, I developed osteoporosis. Somewhere during the delivery, I broke my hip. However, this wasn't found until an MRI was done later to try to figure out why I was so sick. My liver was more than double the size it should be, and a liver biopsy was inconclusive as to what was happening. I was so tired, I would change my newborn on the floor. I was still throwing up, and with the broken hip, I could barely walk. It was clear that something was horribly wrong. Plus, I looked like an emoji. So I show this photo not to sensationalize, but to show what this looked like. I'm not exaggerating, and it certainly wasn't in my head. This lasted for 3 long months. There never was a clear explanation as to what happened. As a last-ditch effort, my GI stopped the one medication that hadn't been stopped, the 6-mercaptopurine. Within several days of stopping the 6-MP, things gradually started to improve. So you might wonder, my husband who has Crohn's, what happened to him during this time? Well, he came down with shingles. Switch, please. 2 years later, I was pregnant again. This time, my Crohn's was controlled with Pentasa alone. Pregnancy was uneventful. Since my body was making no effort to get the baby out, I was induced at 39 weeks. I had advocated the entire pregnancy for a C-section. I broke my hip and tore with a 3-pound baby. What would a larger one do? The chief OB and I argued over this a couple times. I was persistent. He was persistent that I was just a nurse, and I do quote, "The delivery was disastrous. My daughter's head was stuck for 2 hours. Her heartbeat went dangerously low, and they used a vacuum to pull her out." I quote again, the words to me were, "We're too late for a C-section." I was rushed immediately to the OR to repair the damage. I had problems after the surgery and was worried a fistula had formed. Remember, I have Crohn's. My family doctor sent a stat referral to a different OBGYN who saw me that day. This time I was met with kindness and compassion. I felt like my opinion, both as a nurse and most importantly, a patient, mattered. Next slide. I asked if the same doctor would follow me if I ever got pregnant again. He said he would on one condition. He strongly advised a planned C-section. Oh, and I should really take Declectin. Baby will do much better when you're not throwing up all the time. Third pregnancy and C-section delivery were uneventful. I did develop cholestasis of pregnancy, another liver condition, but it resolved immediately upon delivery. I generally felt well, and my Crohn's got knocked into remission, where it's blissfully stayed until this day. Next slide, please. I would be remiss if I didn't take the opportunity to talk about mental health, because I was an absolute mess. After my first baby, I was mourning the loss of a normal pregnancy. Comments like, "Wow, look how great he is now." It doesn't help. I know how lucky we are. For years, I would wake up screaming, reliving the moment I was told that my baby was coming today. It took years of therapy and at one point even hypnosis for me to sleep through the night. I felt let down by the medical system, a system that didn't believe me when I said something was wrong, a system that wouldn't allow my husband to remain in the room after baby Jay's birth because my baby was in the NICU. I was told I should continue breastfeeding by the public health nurse because it was best for my baby, despite a broken hip and severe jaundice. Declectin could have significantly helped my vomiting had doctors taken a few minutes to look up its effects on Crohn's disease. So medical peeps, and that's all of us, myself included, we do need to do better. We need to listen. We need to ask better questions. We need to work together. So these photos are particularly meaningful to me because a piano became my way of emoting when words failed me. Next slide, please. This story does have a happy ending. My kids are all doing well. My eldest started high school this year and is almost as tall as I am. Although I am quite critical of the medical system, there were some unsung heroes who helped make our journey easier. My GI in particular, I have fond memories of him bouncing my baby on his lap during appointments. I want to acknowledge too that not everyone's story has a happy ending. And for those of you who are experiencing challenges with fertility, pregnancy, surrogacy, fostering, adoption, I hold a very special place in my heart for you. If my story has taught me anything, we are all much stronger than we give ourselves credit for. Thank you for allowing me to share my story with you today.
Oh, thank you so much, Laura. Yeah, that it was very amazing. I mean, it's very brave of you to share that story, and thank you so much. It really, you really went through a lot of challenges, and it's very eye-opening, but also it's kind of hopeful to see where you are today. So thank you so much for sharing. We really appreciate, couldn't have been easy. So thank you so much. Um, okay. So after that, I'm struggling for a transition, but after that, now let's move on to the second part of our talk, which is led by our subject matter experts for the night. So I'm just going to do a very quick introduction as they will be providing a more fulsome description of themselves. So first we have Dr. Cynthia Seow. She is a professor and clinician scientist in gastroenterology at the Cummings School of Medicine at the University of Calgary. She is the North American lead for developing guidelines on pregnancy and IBD, and actually a co-lead of the PACE initiative, which is a strategic research program by CCC aimed at improving healthcare delivery for the IBD community. With over 100 peer-reviewed publications, she is our go-to expert for educational resources. So thank you for being here, Dr. Seow. Next, we have Dr. Vivian Huang, who is an associate professor and clinician scientist at Mount Sinai Hospital and the University of Toronto. In 2002, she received CCC's Women in IBD Award for her outstanding contributions, including the creation of the Preconception and Pregnancy in IBD Clinical Research Program in Ontario. We are extremely lucky to have both Dr. Seow and Dr. Huang with us today. And after that, I'm just going to pass it along. Please take it away.
Okay. Thank you very much to CCC, and a special thanks to Laura. Your story is really so inspiring to all. We understand as physicians the struggles that you've been through and how immensely difficult it was. And I hope that with this presentation that we can provide hope actually to many others. I've been running the IBD and Pregnancy Clinic here in Calgary for 15 years now. We have seen significant advances in the management of IBD and pregnancy. And, Vivian and I and myself, and there are others around the country, really have a passion for helping out patients so that, the dreams that they have in terms of family planning can be lived. So with that, we wanted to provide a few slides. It will be back and forth. We can advance the slides. Between Dr. Huang and myself, we have set up a few different clinical scenarios. These are our bios. We can keep going. Thank you. And wanted to firstly introduce and make you all aware that if you Google piano IBD, like playing piano, so very, very, very apt for Laura's introduction, that there are an abundance of resources on the management of IBD in pregnancy. Specifically, there were almost 50 of us who met recently, and it led to the publication of the Global Consensus on the Management of Pregnancy in IBD. There are patient videos in more than 10 languages on the site, so a short video there. There are documents that you can download. There are questions that you can download to ask your gastroenterologist. And this effort involved many physicians from all continents, as well as specialists in different areas, including placental doctors, breastfeeding doctors, pharmacists, surgeons, as well as a patient advocate from each continent. So I really encourage you to just Google piano IBD or pianostudy.org as you see there. Next slide. So I wanted to just set the stage by case number one. So I'm going to present this. I'm going to ask a few questions of Vivian and she will answer those. But case one is a patient called Layla. She is 24 years old. She has Crohn's disease affecting her colon, her ileum, and also has perianal disease. She is treated with infliximab and methotrexate, and she's getting married in a few months and asks her gastroenterologist several questions. These include, will my child have IBD? What factors influence my ability to get pregnant? And I may not be considering pregnancy right away. Why should I see you before I plan pregnancy? Next slide. So Vivian, in this first section here, we wanted to talk about some of the maternal factors of impacting pregnancy. Next slide. My first question to you will be, will my child have IBD? Go ahead, Vivian.
Certainly. So I would say it's not for sure that your child will have IBD. And what we mean by that is, yes, genetics does play an important role. So we do know that if someone has a family history of IBD, so if a child's born to somebody with IBD, they may be having a higher risk of IBD than someone who doesn't have family history. But what I usually emphasize when I talk to my patients is IBD is very multifactorial. So it's not a genetic passing on. So don't worry about passing on IBD to your child. We try to emphasize more to focus on modifiable factors. And what that means is a lot of the research, as Cynthia has mentioned over the years, there are some suggestions about the role of diet, also in the mother, like during the pregnancy, to have a healthy diet, avoiding too much of like processed foods or those kind of like junk food type things. There's some studies that suggest that a mother who smokes during pregnancy, potentially, the child might have a higher risk of developing IBD in the future. So again, that's general healthy practice, is to avoid smoking, avoid alcohol, make sure you're having a healthy, balanced diet, and ensure your IBD is in remission. So the important thing is don't worry about passing like this disease. Doesn't work that way. Can we have the next slide?
Okay. We'll move on to fertility. And again, just to reiterate that concentrate on the things that you can modify. You can't change your genes, but there's many things that you can change otherwise to have the best outcomes. So fertility, next slide. Vivian, tell me, for Layla, she's asking what factors influence her ability to get pregnant?
So again, fertility, very multifactorial. I think that's the theme of today, is
yes, it
is. And so I would say there are things that one can change and things that one can't change. For example, things that you can try to modify is get your disease in remission. And hence, speaking with your gastroenterologist, whoever is looking after your IBD, to make sure that you are in good remission on appropriate medical therapy. That's one thing that you could do. The other thing is, we do know that if you did need surgery, certain surgery like a pelvic surgery, meaning in IBD case, a colectomy, and the internal ileopouch anal anastomosis, commonly called J-pouch surgery, there might be a reduced fertility if there was any damage to the fallopian tube. So in that case, you may request and talk to your healthcare providers to have a referral to fertility specialists, because you may need assisted reproductive therapy in that case, such as IVF, in vitro fertilization. And the studies do show you have a good success rate with IVF in people with IBD compared to people without IBD. Other things that could influence is if you have other medical conditions, so non-IBD medical conditions, that could affect your ability to get pregnant. So very important to make sure that these other medical conditions are under control as well. And then, as I mentioned earlier, nutrition, prenatal vitamins, substance use, all of those play a factor. So IBD is one thing, but you have to look at the overall picture.
Okay, thanks, Vivian. So as we move on, we're going to talk about preconception counseling and optimization. So you've already mentioned that we can't change our genetics, but you can modify environmental factors, your diet, your exercise. You can optimize your disease control before pregnancy. So Layla's next question is, but I'm not quite considering pregnancy right away. Why should I see my IBD doctor before pregnancy? What are they going to advise? Next slide.
So I would say you may not be planning, but again, people, you can always have an unplanned pregnancy. So you do want to be making sure that you are in good health. So for example, in Layla's case, she is on infliximab and methotrexate. So methotrexate should be stopped before someone's trying to get pregnant. So even though she may not be actively thinking or trying right now, it allows time to optimize her therapy, get her off the methotrexate, making sure that she'll be okay just on the infliximab biologic. And that does take time. The other things is, again, making sure that the other people in her circle of care are involved to optimize all her other medical conditions. And there are studies specifically in inflammatory bowel disease that does show that preconception counseling does good stuff. So it improves medication adherence, because then we can talk to our patients and educate them about the medications. And I know you're going to be talking about that more, Cynthia, later. And it has shown to reduce the risk of disease flare during pregnancy. And as a result of that, a result of controlling the inflammation, it can improve the baby's health as well. So planning is good. And I always tell my patients, it's never too early to talk about this.
Thanks. So moving on to the management of disease activity during pregnancy, we've talked about Layla. We're going to give you another case, and then there'll be a bit more back and forth between Vivian and myself, but I'll introduce this case. This is Sabine. She's 34 years old. She has ulcerative colitis. I think we talked about Crohn's already. And she's on mesalamine. That has a number of different names you might have heard of, that you've heard of. They're 5-ASA agents, and you can use them oral and rectally prior to and during her pregnancy. She is now 18 weeks pregnant and has noticed an increase in bowel movements, previously once a day, to currently 4 to 5, but very small stools per day. She's just got a lot of urgency. Stool's a bit looser, and she started noticing blood in a stool. So Sabine's questions are, next slide, am I having an IBD flare, or are my symptoms pregnancy related? Because is this just simply hemorrhoids? Do I need to worry? What tests for IBD activity can be done during pregnancy? And I'll give you a bit of a spoiler alert that you need to monitor disease activity even more closely during pregnancy. Next slide, and over to you, Vivian.
Yeah, so for sure it can be hard to know what's happening with your body during pregnancy. And you can have those GI symptoms of constipation, diarrhea, cramps, but it does not necessarily mean you have active disease. For example, like Cynthia mentioned, you could have blood in your stool, but it could be from hemorrhoids, not from colitis activity. On the other hand, you can have active disease and feel okay. So how do we monitor the IBD? How do we help you understand what's happening? Usually a gastroenterologist may recommend blood tests to check your blood counts, check inflammatory marker in your blood called C-reactive protein. However, C-reactive protein it can be affected by pregnancy itself. It can be affected by other non-IBD conditions or infections and other things that cause inflammation. So that's why I know people don't like doing stool tests, but your gastroenterologist is going to order stool tests for you. So what kind of stool tests do we typically order if we're trying to see why people are having these symptoms? So one of them, in the case of having a lot of diarrhea, is to rule out infection. So that would include infections like the C. diff, Clostridium difficile, which is actually higher risk in people who are pregnant and also people who have IBD and pregnant. And then also other like typical things like the things that cause food poisoning, for example. There's a lot of food poisoning happening in Canada, so that needs to be ruled out. And so that's why if your gastroenterologist asks you to do stool sample tests, it's really important to do those. And then in certain cases, we may recommend, as gastroenterologists, we may recommend bowel imaging. And that would typically be intestinal ultrasound because ultrasounds are safe in pregnancy, and there are people around the country now who are doing dedicated ultrasounds to look at whether there's inflammation in the bowel. That's typically gives us better information earlier in pregnancy because you can imagine, when you're in your third trimester, baby is growing and big and pushing the bowel out of the way, so may not have as good imaging. And then in rare situation, you may need to have a CT scan or MRI, but typically those are left for certain situations. And then there's a picture on the left of a gastroenterologist holding a scope. So it's not the first test that we typically would recommend in a pregnant patient. It can be done safely. So if it will change management, meaning maybe the tests that have been done are not giving the information, or maybe it's showing that there's very severe disease and we need to take a look inside to see what's happening, take some biopsies and potentially change therapy, then that may be recommended for a pregnant patient with inflammatory bowel disease.
Thanks, Vivian. And if I can just also be a proponent to say, please do consider the fecal calprotectin. Not only does it tell you how you're doing now, but for all those patients that say, what's the rest of my pregnancy going to be like? What is my next trimester going to be like? The fecal calprotectin, that poop test, is our only predictive test. It not only tells you how you're doing now, it can predict how you're going to be in 3 months' time. And fancy that is the equivalent of 1 trimester. So during pregnancy, it's even more important. Okay, over to you, Vivian.
Yeah, so next slide, please. So staying with Sabine, she's asking whether it's safe for me to take aspirin in pregnancy. Her family doctor and obstetrician has recommended it, but why? So I'm going to direct that to you, Cynthia.
Thanks. So this is an important thing that's come up in the global consensus, but actually is not a new topic for those who are obstetricians and those who are used to delivering babies. So there will be a proportion of patients who are at higher risk of having high blood pressure during pregnancy. And so that is called preterm preeclampsia, because preterm means that it occurs earlier in the pregnancy, before 37 weeks. What I really want to emphasize is that IBD may be one potential risk factor, but as you heard from Vivian earlier, everything is multifactorial. So this statement doesn't mean that everybody with IBD needs to be on aspirin to reduce this risk in pregnancy. There are many other risk factors for it that your family doctor and your obstetrician will guide you about. They, for example, include being older age, having an assisted reproductive therapy, having other chronic diseases, having a high blood pressure in your previous pregnancies, or having a family member with it. What we simply want people to remember is that you should ask your family doctor when you are pregnant, or your obstetrician, whether you should be started on aspirin. And if you do require it, then it is safe. It will not make your IBD worse. But similar to anything else, for example, you don't need to take if you don't need medications, you don't need to take it. So we do not ask for everybody to take aspirin during pregnancy. And if you do start it, it will be around 12 to 16 weeks of pregnancy, and you continue all the way to 36 weeks of pregnancy. So just a point of clarification, because we're getting a lot of questions about it.
Yes, and I think as Cynthia, you mentioned, I think one of the concerns in the past has been people who needed to take it because they had those other risk factors. They were told that they shouldn't take it because they have IBD. But as you mentioned, there's no increased risk of flaring by taking this.
Yeah. And that's why we want to emphasize, that it's going to be on the next slide, that this is a collaborative model.
Yeah.
So I'm going to ask, Vivian this, but why is it important that we are all talking to each other? So Sabine then asked, well, you've just mentioned this about the aspirin thing. Who do I need to see during this pregnancy? There are so many physicians and care teams. Who do I see? And before Vivian answers it, can I just say that as gastroenterologists, even if we run an IBD and pregnancy clinic, we do not deliver babies. So over to you, Vivian.
Exactly. I think that's exactly what you're saying. Like everybody in the care team, we all have different expertise, different roles, but we all work together to try to help the person through this journey. And so what that means is, for example, the primary care provider will help coordinate everything and knows all your medical history, your socioeconomic concerns and everything. You may have a primary gastroenterologist is how I term them. You might not need to see someone like Cynthia or myself, it just kind of depends on who's in your circle of care. You may have a surgeon if you have IBD and is affecting the perianal Crohn's, or you've had the surgery and the J pouch. You might have a surgeon as part of your healthcare team. So this circle of care it may be different for each person. But what I always say, that question earlier about why do we need to see the gastroenterologist early, is because to help identify who is in your circle of care and get everybody connected and help you through the entire journey.
Fantastic.
Next slide.
So Sabine then asks, do I need to have a cesarean section? And again, we're not the ones doing the delivery, but we certainly have a role. And what is the role of a gastroenterologist here?
Yeah, so again, that's where this whole circle of care comes in, because from the gastroenterology point of view, I think the two main gastroenterology reasons that we may recommend that someone discuss with their obstetrician about having a cesarean section is if they have active perianal Crohn's disease, or if and that's just to try to reduce any further damage down at the bottom. But also if you have had a colectomy in the internal J pouch, it is suggested to discuss with the obstetrician about having a planned C-section, just to try to reduce the risk of any pouch dysfunction or damage to the anal sphincter in the future. And then there's one that's not listed on here, but if someone has had rectal vaginal fistula in the past or present, then it is also recommended. However, the main reason for cesarean section, I think, is actually an obstetrical reason, and also personal preference. So again, we're just here to provide information and advice, but the person who's delivering you is the obstetrician.
Yeah, and maybe just to add, so the obstetrical reasons, as I like to tell patients, is that, baby's head's too big, baby is, sunny side up, feet first, all those kind of things that a little rascal will do. Those are obstetrical reasons for recommending a C-section. Next slide, thanks.
Right. So I think the next section now is the big, huge section that everybody has questions about, is IBD medications during the pregnancy. So next slide. So Sabine is asking, can she continue her IBD medications throughout pregnancy? So I'll turn that over to you, Cynthia.
Yeah, thank you. So this is a big section, as Vivian has said. So this is our first a general slide to say, all pregnant women, or even those who are about to embark on a pregnancy, you should be much more concerned about the effects of active disease than the effects of active medications. And it crosses over a little bit to what Vivian will be covering soon, but very, very simply, your body needs to be focusing on forming baby, not trying to keep your colon or your small bowel under control. So the more attention that you can give to baby, and the less distracted your body is, the better. So the medications truly are an adjunct to help you achieve what you need to do to get through this pregnancy. And as you will soon see, truly the vast majority of IBD medications can and should be continued during pregnancy, because when you think about it, what worries mums? We understand what worries mums is the risk of birth defects that we also call congenital malformations. It is important to know that the baseline risk in a population of birth defects is about 3 to 6% in the general population. And so sometimes it is not the drug, because this is in the general population. So birth defects occur sometimes for reasons that we don't understand. However, it's important to know that active disease in itself can act as a teratogen, meaning that it can cause birth defects, again, because your body is distracted. And we'll talk about in the next slide, if we can move on, which of these medications actually cross over the placenta and what can or should be considered. So this is an overall slide just telling you about the names of the different drugs. So you might be able to identify on here which ones that you're on, and then we'll go through the, because we've just got so many varieties of medications, as Laura said, in the past, 5-ASA, steroids, and thiopurines were all that we really had. And if you move on to the next slide, this is actually a really good news slide that you will see here. Look at all the green ticks. So first of all, if we go through this briefly, aminosalicylates, so that's things like pentasa, salifolk, and mezavant are 5-ASAs. They can be given as a tablet, or as you well know, they can be given as a suppository, especially for people who have rectal disease and have a lot of bowel urgency. During pregnancy, ulcerative colitis is at risk of flaring, and it's already hard. You already have some bowel urgency when you have UC, but when you are pregnant and you've got a baby jumping up and down on your rectum, it also makes you want to go to the toilet. So rectal 5-ASA can be a useful adjunct. It is absolutely safe to use this class of drugs during pregnancy. How they act is they line the bowel. They do not cross in. They are not systemically absorbed. So if you need to be on any of the oral or the rectal, pentasa, salifolk, mezavant, I could go on and on for the class of drugs. It is safe preconception and all the way through pregnancy and safe for breastfeeding. Next class of drugs are the thiopurines that include azathioprine, 6-mercaptopurine. And in general, there are exceptions, as Laura has said, it is a relatively safe drug in pregnancy. Again, if it's needed to maintain disease control, you should continue it. There is a small risk of causing intrahepatic cholestasis of pregnancy, and quite simply, that means, as Laura said, that it can affect your liver because it's metabolized by the liver. It's important to know that about 1.1% of the general population develops that itching and the liver abnormalities irrespective of drug use in pregnancy, but it can be exacerbated by thiopurines. Generally, if you're on a thiopurine and it's keeping your disease under control, you would continue it. But we really ask you to talk to your gastroenterologist to see whether there are other therapies available to you. And whilst everyone thinks, oh, it's just a pill, it should be the safest one, there are potentially safer or more effective options for those with moderate to severe disease. And I will repeat that. That is safer or more effective only in those with moderate to severe disease. We are not switching everybody to an advanced therapy just because they're on a thiopurine. Where are all the X's? The X's are on methotrexate. And as Vivian already mentioned, a woman should stop methotrexate at least 3 months before planned pregnancy. But we would advocate actually that if you are female of childbearing age, you should see your gastroenterologist and say, are there better options for me? Because as we said, we know that some pregnancies are planned, but we also know that there are many that are not planned. If you are exposed to methotrexate during a pregnancy, however, there is a risk of congenital abnormalities or birth defects, but it doesn't occur in every pregnancy. It does not mean an automatic termination. I will really repeat that. You need to see an obstetrician, get an early scan, and then be provided with the options, because not every pregnancy exposed to methotrexate will end up with a bad outcome. But as we've kept saying, there are safer and more effective options than go for those that are necessary. So corticosteroids, that's your prednisone or your Entocort or your Cordiment. They can be used to control a disease flare. They put you into remission. They make you feel better, but they are a bridge. They get you better to something, and you need to bridge over to a more appropriate maintenance therapy. There's many times where we cannot predict a flare in IBD and steroids will be needed. But if somebody is requiring repeated courses of steroids before the pregnancy, it really means that they're not on the appropriate maintenance agent. And again, that's why we advocate that you go and see your doctor earlier to say, hey, I keep requiring steroids every now and then. Are there more appropriate therapies? That leads us to the big section, the biologics, which you know are big proteins. They include a range of drugs. I'm not going to go through every one, but if I say it quickly, they include the infliximab, the adalimumabs, the golimumabs, ustekinumab, risankizumab, mirikizumab, soon to be the guselkumabs, and the vedolizumab. I hope I didn't miss any on that quick run, but they're all huge molecules. We in the past were concerned, and I guess many of you are concerned about whether you can use these advanced therapies in pregnancy. But guess what? The news is actually so incredibly reassuring. These drugs are very effective at getting your disease under control, and they should be continued during preconception, pregnancy, as well as during breastfeeding to maintain that disease control again, so that your body can concentrate on forming baby and not be concentrating on your bowel. Because they are huge molecules, they cannot actually cross the placenta in the first trimester. I'll repeat that. They do not cross the placenta in the first trimester, so they are not responsible for birth defects or also known as congenital anomalies, because baby cannot see them, hear them, smell them, anything, because they do not cross in the first trimester. So we advocate that if a patient is on a biologic agent, that you continue it all the way through pregnancy, all the way through breastfeeding, and you don't change the schedule, you do not change the dose. Why do we say that? Because over the last 15 years, there has been an explosion of research into the safety of these drugs during pregnancy. We have found that in the past, people were worried about it. They used to stop the drug early in the pregnancy and say, well, they seem well. Let's see if there's a disease flare and then we'll deal with it. Guess what? No surprises. You stop the drug, the woman flares, they need rescue therapy with steroids. That is super stressful to a mum. It means you're changing therapy and you may be exposing your baby to that risk of active disease, as well as this uncertainty of what drug you're going to go on or whether you will respond to the drug when you reintroduce the original drug. So we recommend that you continue it all the way through preconception, pregnancy, and for breastfeeding. Many have asked, will it cross into the baby's bloodstream? And yes, there will be a small amount that will go into the baby's bloodstream, but I want to reassure you that there have been a multitude of studies showing that it doesn't affect the baby's immune system. I know that might be hard to believe, but we have looked at these babies. We have had a pediatrician look at them. We've done blood testing on the babies where the mums have allowed. Not only did these babies not have an increased risk of infection, all their immune cells were normal. We've given them the non-live vaccines, all the standard vaccines, and now we're even providing these babies the live oral rotavirus vaccine. And you know that most pregnant women aren't supposed to take a live vaccine, but these babies are well, and they can receive the live oral rotavirus vaccine, which is the leading cause of neonatal diarrhea. And we've seen no abnormalities in those babies, no increased infection risk and safety, because we provide them protection against developing infections. This is not just our center or several small centers that have looked at this. This has changed public health rules across Canada, and with the global consensus, we are reminding people that there is no increased risk of infection with these drugs and that we can further protect these babies by giving them vaccines. And these vaccines are considered safe for the mum, safe for the baby. And I know I'm preempting things as Vivian is going to ask me about vaccines later, but it's part of that story. So you can continue the biologics all the way through the pregnancy and all the way through breastfeeding. The amount that passes into breast milk is minuscule. We say safe is less than 10%. The amount that's passed is less than 0.005%. And it's no longer blood-to-blood transfer. It goes in the baby's mouth. Baby will digest it like any other protein that they're eating, whether the mum's eating steak or whatever. It gets metabolized. Special discussion about two newer molecules that you may or may not have heard about yet. The JAK inhibitors, also known as tofacitinib or upadacitinib, better known as Xeljanz or Rinvoq. The S1P modulator that is called etrasimod, also known as Velsipity. These are great drugs. However, they're not recommended necessarily as first line in someone who has not been exposed. First line means that you've not been exposed to any other drug. There are other safer alternatives in pregnancy. There are some exceptions where a patient has already unfortunately cycled through multiple drugs and has not got their disease under control until they got onto a JAK inhibitor, again, also known as Xeljanz or Rinvoq. In those cases, if they have no other viable alternative to keep the disease under control, we would ask that the patient continues on the drug. We don't stop it and see what happens because we know what will happen. And the problem is if they've been already on a lot of other drugs, you don't have any other way to go. So we keep those mums on the drug if there's no other alternative. Again, that's why Vivian said you need to see your gastroenterologist early so that you can plan this. You don't just simply switch and see what happens. It needs to be purposeful. It needs to be planned. And I want you to all be aware that there is a lot of research going on into looking at the safety of these small molecules, which are the JAK inhibitors and S1Ps, because we were worried a little bit about it in animal studies. We're not animals, we're humans. And in fact, the emerging human data has actually been very reassuring. So I just want to remind people of that. Again, the biggest messaging here is be much more concerned about active inflammation because that can harm baby, and don't be so concerned about active medications because hopefully I've managed to demonstrate that these drugs are generally very low risk in pregnancy and keep your disease under control, and we are happy to answer further questions about that in the Q&A. So sorry, that was a lot of chatting. Vivian, next slide.
I think you kind of answered some of these questions, but yeah, I guess I'll just emphasize like what you had mentioned earlier about the IBD medications, to stay on it right through pregnancy. So any additional like tips or tricks for the patients if they had to change medication, for example, the JAK inhibitors that you mentioned, like if they need it, stay on it during pregnancy. What about in breastfeeding? Like can they stay on the JAK inhibitors in breastfeeding?
Yeah, so most of the drugs, as we said before, with the exception of methotrexate, are considered safe for breastfeeding as well. I think that the breastfeeding issue is a little bit vexed. The first thing here is that we gave the general advice, and you'll see why I come back to it, that breastfeeding does not increase the risk of a disease flare. Because in the past, it was thought that breastfeeding increased the risk. And why could that be? It was because the majority of women had the baby, came off the medications because they were scared it would cause harm to the baby, and then they had a flare. So that's what we call confounding. It wasn't the medications that led to the disease flare. It was coming off the medication that caused the disease flare. We also want to iterate another important point that whilst there's a lot of discussion about the benefits of breastfeeding because of the passage of protective immunity to the baby, that's a plus. There is an aspect of bonding potentially with the baby. Not every single woman will choose to or want to or be able to breastfeed. So I think that's important as well because I think a lot of people get very hung up on it. So that's an important discussion again with your obstetrician, your family doctor, as well as a lactation consultant. At this point in time, we do say that the majority of medications are safe during breastfeeding. We are also doing studies on those new JAK inhibitors, looking at breast milk concentrations. So far, it's a small number of women who have chosen to breastfeed while on the drug, and we have not seen an increased risk of infections. And how else can we prevent infections? Exactly as we said, that you vaccinate both the mum, because the mum will provide protective antibodies, and you also immunize the babies. So I think those are 2 points, but generally, I hope the message is that it is safe and it is effective to continue medications during pregnancy and breastfeeding. And if we move on to the next slide, Vivian's going to give you further reasons. We've talked about how having active disease may be harmful to the baby, but we'll go into a bit more depth. We didn't want to start off by scaring people, but we want to ask you questions now because Sabine said, okay, that's all well and good. You've told me I can go on medications, but is it really important? Why do I need to keep my disease under control? So question 7. Vivian, are women with IBD at increased risk of bad pregnancy outcomes? And what can you do to avoid that situation?
So I would tell my patients that it's when you have active IBD, that's when you should be concerned, because it's the active IBD that puts people at increased risk for these bad pregnancy outcomes. So what do we mean by bad outcomes? And that means
Right.
things like pregnancy loss. People who have active IBD in the pregnancy and uncontrolled disease are at higher risk for spontaneous abortions and miscarriages. They are higher risk for baby being born too early, so preterm babies. And babies who are born too early, may be at higher risk for complications in the future. So, the thing that you can do to avoid that situation is to keep the disease in remission by staying on the appropriate medical therapy. What Cynthia has already talked about, all the different medical therapies. And I think you've emphasized in before that it's when the mom is very actively, like, the IBD is very active, they can't eat, they're vomiting, they're having diarrhea, like they're going to be malnourished, and then the fetus is going to be malnourished, and the baby would be born too small and low birth weight. So the one thing that people could do to avoid or try to reduce the risk of bad pregnancy outcome is to keep the disease in remission by staying on the maintenance therapy.
Mm-hmm. Next slide.
Yeah, so this is just trying to, I guess, because people get, like, as you said, Cynthia, like, used to be concerned, like, oh, like, I'm taking the medication, so I'm maybe doing something harmful, but it's actually not taking the medication and allowing your disease to get very active. That's when it's higher risk for these adverse outcomes. The one thing we didn't mention actually was the risk of blood clots. So that's important to know as well, that active IBD can increase the risk of blood clots, and then pregnancy can increase the risk of blood clot. And then if you're hospitalized or if you need a cesarean section, that increases the risk of blood clots. So it's just something to remember. And if you're in the hospital and your obstetrician, after the C-section says you need to take a blood thinner, that's why. It's to try to reduce that risk of blood clots. Just a note there, because we didn't talk about that earlier.
Mm-hmm. So we move to the next slide. We've talked about the risk to the mum, but the following slide is about the babies. So Vivian, can you tell us what happens? Are babies born to mothers with IBD at increased risk of bad pregnancy outcomes? Can you tell us a bit about the risk of flare in the mum, which you kind of covered, but also the risk of preterm birth? What is it and why are we worried about it?
Yeah, so it's when the mother has active disease in the pregnancy that, I guess, the numbers are, like, varies depending on which studies you look at, but it's about 2 to 3 times or maybe higher risk of having a baby that's born too early when your IBD is active compared to if it's in remission. So again, you can try to reduce that risk by getting your disease in remission and staying in remission. I think the other thing, you mentioned it earlier, that people used to be worried that, oh, baby was exposed to biologic and they might be at risk for infection, but it's not. It's when they're exposed to the steroids. Like, the mom needs steroids throughout pregnancy. Obviously, we will use steroids as needed, but we try to get off the steroids and onto a biologic because it's when the baby was exposed to a lot of steroids in the pregnancy that they might have risk for infection in that first year of life. So it's not the biologics that cause problem for the babies.
Yeah, and if I can also add, so as Vivian said, a preterm birth means that babies come before 37 weeks. We always tell our patients, doesn't mean if a baby comes earlier, they are still very cute, they are very small, but you have to remember what hasn't fully developed. And it's usually the immune system and the neurological system. So as we said before, it is not exposure to drugs that increases the risk of infection. It is when a baby comes early that the immune system is not mature, it is not strong, it is not robust, and those babies are more at risk of developing an infection because they were born earlier. So if we circle back on it again, if we can keep a patient's disease inactive by keeping them on medications, meaning that you dose all the way through the pregnancy on the regular cycle, you do not need to change dose, you do not need to withhold the drug anywhere during the pregnancy. That's a big change. I've seen that come up in the Q&A, and we will get to all your questions soon. But if you can keep that schedule going, if your disease can be kept under control, then the chances are that the baby will be born term, which means that they have a better immune system and a better neurological system, their risk of developing infections decreases. So it's a win-win across it. Again, infections is related to inadequate disease control. It is not related to the medications. And, that's been a major change in the teaching over the last 10 to 20 years. So that's why we're harping on it so much.
Great. And then next slide. So now again, I think Cynthia kind of started talking about the
Yeah,
vaccinations, but I do see a few questions popped up in the Q&A. So I
Yes.
think we're going to ask you now to go over a little again, which vaccines can or cannot the pregnant woman receive?
Yeah.
And then which vaccines can or cannot her child who may have been exposed to these biologics receive?
Thanks. So again, it is really important that women with IBD get their appropriate vaccines because especially when they're pregnant, whatever antibodies that they develop that are protective, they will pass to the baby. So another win-win situation. It is true that a woman cannot receive a live vaccine during pregnancy, but there are no scheduled live vaccines during pregnancy for this obvious reason. So it doesn't matter what drugs you're on. If you are pregnant, you won't be advised a live vaccine. So what are the vaccines that pregnant women are recommended to have? And this is based on Health Canada's, our public health website. It is based on our discussions with the Society of Obstetrics and Gynecology of Canada. So it's called the SOGC. It's based on Canadian Immunization, the CIRCLE as well. So this is all online and your obstetricians will tell you about this. We advise DTaP that helps prevent against things like whooping cough. We recommend RSV that can be provided by giving it to the mom, the vaccine, or that you can get a drug to the baby afterwards. Those cause respiratory infections. And similarly, we try and prevent against influenza. So for every pregnancy, you do recommend these vaccines at each pregnancy. So that's the DTaP for whooping cough, RSV for lung infections, influenza for lung infections, COVID. Situation has changed a little bit, but again, it will provide potential immunity to obviously to mum and to baby. And specifically for IBD women, if you are on an advanced therapy, then you should receive the pneumonia vaccine. So that at the moment is called the Prevnar 20. And so we're advising all our patients, irrespective of the age, if they're on an advanced therapy, to get the Prevnar vaccine. There has been a little confusion, so I would just want to clarify it that in the general population, if you have to be 65 and older to get the Prevnar vaccine or 50 and older on an advanced therapy, but we're advocating to change public health recommendations to get it for all IBD patients on an advanced therapy, and particularly in pregnancy because you can pass this over to the baby. So we don't believe that there adverse effects of receiving vaccines during pregnancy. We know this is a vexed issue. We would ask you to discuss this with us as well as discuss it with your obstetric provider. Again, this is for the benefit, not just for the mum, but for the baby. So when we look at the baby now, which vaccines? There is only one that the baby cannot receive, and that's the live BCG vaccine. That's only used in certain communities, and if that was advised in that particular community, then we would recommend, if possible, to hold it until after 6 months. We know that there are certain countries in the world where people are more likely to get tuberculosis, and each jurisdiction will advise what is the risk or the benefit of it. The risk of giving a live vaccine is that the baby will then develop tuberculosis, but in some places in the world, and that's why it's a global consensus, they are like, if we don't vaccinate, our baby will also get very sick. In Canada, however, the rates are very low, so we say avoid the live BCG. Reminder that all standard childhood vaccines given at months 2, 4, and 6, and then 12 months can be provided to the babies. They are all non-live vaccines. They include, the Hib vaccine, hepatitis, other things like that. All of those can be given to provide immunity for the baby. Further, we have been working with public health, and the live oral rotavirus vaccine, which is recommended before 15 weeks of age, that can lead to severe diarrhea, is the leading cause of diarrhea in infants, can be provided to babies who are exposed to advanced therapies during that pregnancy. Each province does it a little bit differently. Some of our public health have already approved it across the board. Others still prefer that you see a pediatric infectious disease doctor to have this exact conversation, a more detailed conversation than what we're giving you now, to reassure you that there is low risk of receiving it and you could protect your baby. It's not very fun for a UC or a Crohn's mum to have a baby with terrible diarrhea. You guys know what it's like. For an infant, you don't want to see the infant suffer either. The last part is about the measles, mumps, and rubella vaccine. At this point in time, this is a live vaccine. It's only provided usually at 12 months of age because the mum provides the immunity before that time, right? Because the mum's already been immunized. So there is a question about mum providing immunity up to 6 months and then the vaccine occurring at 12 months. There is a bit of a change in public health at the moment, and you may be offered the early measles vaccine for your baby between 6 and 12 months. That is province dependent at the moment. We have done and looked at the studies. We've talked to pediatric infectious disease, and they do not believe that it increases the risk even in babies who are born to mums that were taking drugs during the pregnancy. So to simplify it all, vaccines for the baby to protect the baby, vaccines for the mum also to protect the baby. The only exception here is the live BCG vaccine. And I promise you, when you go to the vaccine clinic, this will not be left to you as a query. Of course, there is personal choice, but when you go to the public health clinic, they know your medication history. You can remind them of your medication history, and they will provide you the advice for each case. So hopefully that's reassuring, because we know that this is the most complicated issue. And again, the drugs don't increase the risk of infection in a baby. It is uncontrolled disease and a preterm birth that increases the risk. And vaccines are meant to be preventive. But we know, I can see out of the corner of my eye, the chat box opening up there. We will answer all your questions in a little tick. Next slide. Vivian, want to present the summary?
Sure, yeah. So basically, I think the bottom line is healthy mom means healthy baby. So be more concerned about your active disease than taking medications. So as Cynthia emphasized several times, and I tried to emphasize, it's the active disease that can cause problems in the pregnancy and also cause problems for the child. So the risk of that disease activity outweighs potential risks with treatments. So basically, continue your IBD medications before pregnancy, during pregnancy, and while breastfeeding, with the exception of the methotrexate, and then in certain situations, the JAK inhibitors and small molecules. So basically, we try to emphasize that the goal is to get your disease in remission and keep it in remission before, during, and after pregnancy. And then finally, protect your baby. So vaccinate yourself, which also means that you'll vaccinate your baby, and then the baby also can get their standard vaccinations. And again, there's a little a website there. So there's a lot of resources, as Cynthia mentioned there, which outlines the global consensus, patient videos. There's also resources that you can direct your gastroenterologist and your obstetrician to if they want further information as well. So thank you all for your time. I think there's a consensus again, and there's some other resources here, which I think CCC will make available to everybody. Great.
Hey, thank you so much, Vivian and Cynthia. That was amazing. Thank you for putting together, the global consensus on pregnancy and IBD, and for really alleviating any worries that individuals who are considering having kids may have. So before we get into the Q&A portion, now that we've had all this learning, I'm going to launch a poll again, and this time it's going to be requesting folks to talk about, to assess how they feel post-event. And I'll give everyone about 30 seconds. It's looking good. Vivian is in there. The numbers have gone up significantly as a testament to how well both of you explained everything. Okay, I'm going to end the poll and quickly share the results. So if we remember in the start, the values were clustered around, 1 to 3, 1 to 4. And as you can see, they've all now moved into 7, 8, 9, 10. So this is amazing. Super glad to see that, the numbers have gone up and that everyone feels like they've learned something. So thank you, Dr. Vivian and Cynthia, for sharing all your expertise with us in such an accessible way, which is really important. Okay, so now we will move on to the Q&A. I just want to again share that if you have any questions, I know there's a few questions, so we will try our best to get to them. They're in the Q&A box. And again, we won't be answering any questions about individual specific experience or specific situation. We try to keep them general and follow through. Okay, so the first question is, since IBD can be inherited, what are the chances of it passing on to your children? You did cover this briefly at the start.
I'll just add again that remember, genetics is only one small aspect. It's different to other diseases. Worry about the things that you can change, not the things that you can't change. And it doesn't mean that if you have IBD, that your child will definitely have IBD.
Thank you. Okay. And the next question is, can you speak about women in their 40s with IBD who want to become pregnant? Also, what about the use of biosimilars in IBD?
Yes, I'll answer the first question. So if it's if you're older age, I guess is what they say, 40s and stuff. But if you're trying to get pregnant, I would just say if it's in your family planning and everything else is working out, that's the time that you are trying. Just talk to your family doctor, your gastroenterologist, because we shorten the time. So meaning we don't wait like a year and 2 years and 3 years and you're having trouble getting pregnant. It's less than 6 months. And if you're interested in a fertility referral, then bring it up and ask for it. But that's the one thing I would say. I think people are a little
And
bit
I'll add one thing to it as well, if you don't mind, Vivian. Please remember, the females get blamed if there's no pregnancy happening. There are male and female factors. I want to remind you all that if you are not getting pregnant, say by 6 months of active trying, as Vivian said, go and speak to your gastroenterologist or your family doctor, because the initial tests that are done that check for fertility issues in males and females should be covered by your provincial healthcare plan. It is true that assisted reproductive therapy is not covered by public health plans, but the tests that see, is there a male problem? Is there a female problem? If it's either or, how do we fix it? Those tests are covered. So don't delay. If you are seeing a fertility doctor, it doesn't mean they want your money to go onto IVF. It means that they're trying to determine what's going on. Then they present you with those options. And why we really, really, really emphasize this is that many people are very reluctant to go and see the fertility doctors because they think that that means that they are subfertile, infertile. That is not the case. There might be things that can be fixed. Remember that active disease can lead to subfertility. And also remember, before you embark on anything, because we've seen the questions there about, egg freezing, implantation, all those kind of things. The best way to enter that situation is if the mum and dad's diseases, respectively, are under control. Remember that all the assisted reproductive therapy, it's not only time consuming, it's emotionally very, very, very consuming, and it's also financially consuming as well. So the best that you can do to get your disease under control, because it's very disheartening for someone to go there and be told all the options for treatment, and then it comes back down to, your IBD is not under control. That's what us as gastroenterologists are there for. Sorry, that was a very long answer.
No, thank you, thank you. Okay, on to the next question. Again, you've covered this extensively throughout the talk.
But we didn't cover the biosimilars, just to mention the biosimilars
yes.
have been demonstrated to be as safe as the originators, so no concerns about that. That still comes under the biologic therapies.
Okay.
Actually, I'm going to ask Cynthia one question because it comes up still, biosimilar switching during pregnancy.
Yeah,
because of
I think
the
we've been very reassured. The reason why we had asked for compassionate access to continue an existing drug before switching during pregnancy was more just to relieve the emotional stress that it is on the women. To be honest, there were no medical concerns for it, but a woman's pregnant, then she's dealing with insurance companies, then she's dealing with this, that, and whatever. She's trying to take maternity leave, trying to plan for all of that, planning financially. It was an emotional stress. There is actually no medical evidence to suggest that it is harmful to switch the drug during the pregnancy because a biosimilar is very, very similar, not exactly equivalent, but we have seen the data and we're not concerned. So I hope that answers that.
Perfect. Thank you. Okay, the next question is, can someone continue their usual colitis medications during pregnancy?
Yep, I think we've covered that, just not methotrexate.
Moving on. The next question is, what are the implications before and after pregnancy for people
I
on
think we've covered that too.
Okay, moving on. Okay, I received multiple questions around this topic. I
Maybe
picked
you want to lead this one?
So I'll quickly just read out the question. What should men know about medications or inflammation while trying to conceive? Do IBD medications, including biologics, affect sperm?
I guess I'll start off with this and then direct to Cynthia. But basically, it's the same thing for the man as well, is to keep your disease in remission. Because if you're sick as well, then the sperm health could be affected. The one major IBD medication that is known to potentially affect sperm health is sulfasalazine. So if a male is having trouble conceiving and they're on sulfasalazine, potentially that could be a reason. But biologics do not affect sperm health. And then I guess I'm going to ask Cynthia. It used to be controversial, but I think it's the methotrexate question in a male one.
So I would say as Vivian said, to reiterate that all medications that maintain paternal male health should be continued, because if you don't have, even if we take it one step back, I tell my patients, if you have active disease, either male or female, there's also a higher risk of sexual dysfunction. When we talk about sexual dysfunction, we talk about this term called hypoactive sexual desire disorder. It means you're not in the mood. If people are not in the mood, if they've got sore joints, sore skin, they think they're going to poop in bed, there's lots of things like that. So I always take it one step back and we've covered that first. Then we talk about all these drugs, and it's important to know that the sperm in itself will not carry a genetic defect on account of the medication. Most of the times, if there are minor sperm abnormalities, what they do is they change the morphology. That means maybe the shape of the sperm a little bit. They don't completely affect function. They just make the swimmers a little bit slower. And so that's why we always advise it is important to go and see a fertility doctor so that you can figure out whether it's male or females. I just saw it pop up about, JAK inhibitors in males. There was a little bit of concern about filgotinib, which is one of the JAK inhibitors that's not provided here in Canada. There was, it's used in other areas of the world. There were concerns about motility, mainly, and morphology and poor swimming, not that of a genetic defect. It doesn't increase the risk of birth defects. It just means that it might take a bit longer to get pregnant, and that's why you should see somebody in the fertility space, and they will advise accordingly. I think it's a similar question.
Yes, we've covered this. The next question is, what are the risks of pregnancy and breastfeeding while on Entyvio? What about the risk of flares during pregnancy?
Yeah, so I think we've covered this as well, because Entyvio is one of the monoclonal antibodies or a biologic that's in pregnancy, and it is similar statement, as we said before, they are too large to cross the placenta in the first trimester. They do not lead to birth defects. We try and use it so that it reduces the risk of flare during the pregnancy. No change to dosing, no change to dosing schedule. Continue it all the way through the pregnancy.
Perfect. You've also covered this. Do biologics need to be fully out of your system before trying to conceive? That's a no. The next one, should people with IBD take additional prenatal vitamins or supplements when trying to conceive or during pregnancy? Are there extra tests or protocols we should follow when preparing for IVF?
Vivian, you talked about preconception
Yeah,
counseling.
standard prenatal vitamins are usually sufficient. I think it's we would just generally tell people if they're on sulfasalazine, for example, then they should take a higher folic acid, 2 milligrams or higher. If you've had a lot of surgeries for your Crohn's and you have like short bowel or like risk for malabsorption, then you should take a higher folic acid. Otherwise, other prenatal vitamin supplements would actually be individualized, like based on your blood test. If you're low in vitamin D or low in vitamin B12, then they may recommend that you take extra supplements. I guess the other question about IVF, I think we sort of touched upon that. Basically, what Cynthia had mentioned earlier was the most important thing is to be in remission when you're going to undergo any parts of these IVF. There's different stages for it. So I guess the extra tests in terms of gastroenterology would be like a fecal calprotectin, for example, to assess if there's any inflammation. I think that's the main thing from the GI point of view. Unless Cynthia has any other thing.
No, just make sure that you're as healthy as you can at any stage. And so I think if this also asks about, freezing eggs, all of these kind of things, the better that you can get your disease under control. If you think that IBD is a potential risk factor for subfertility or for worse outcomes, I think it just underscores that we are here to help you out. We're trying to get this disease under control. So not only do we talk about active disease, I see things coming up in the, in the chat box as well. Preventive care, when we talk about it, that's why we talk about vaccinations, because vaccinations are to prevent people getting infections from diseases that are known to cause other adverse effects. We know that that's a controversial issue amongst many. And as I said, it's not mandated. These are what the medical community would suggest, because we have an overall global view of helping a woman with vaccinations. Other preventive care things, if I dare add, that I really wanted to highlight what Laura said, is mental health in pregnancy. Then mental health in someone with IBD in pregnancy is so important. Reach out, because many of the GI clinics have resources for psychosocial health. And very importantly, obstetricians are used to seeing this. They do have resources. And this is something that I'm glad to say has changed. And I felt really sad and bad hearing it from Laura that it wasn't available then. We know it's not a perfect world, but obstetrics has a lot of resources because they're very aware of the hormonal changes affecting a woman during pregnancy, and also the risks of things like postpartum depression. Mental health in pregnancy and postpartum has also been well investigated. So the 4 preventive issues that we look at for any person with IBD are therefore mental health, vaccinations, making sure that you're not at risk of cancer, which can be a byproduct of having chronic inflammation, and then the nutrition piece, including what Vivian's already said about being on a prenatal vitamin, and restoring everything to as best as you can before the pregnancy, because we know that the baby is there to also take out all your nutrients for their own good.
Thank you. Are biologics like Renflexes safe during pregnancy and breastfeeding? Maybe we can just say yes or no to the Renflexes, just so that folks.
Yes.
Yes.
It's a biosimilar. There's also been questions I can see up on the chat box about concerns of using biosimilars in pregnancy or using it in IBD in general. We have, as mentioned, they are similar. They're not identical. We have combed through the data. There were less options available to patients with the biosimilars than we have when the first biosimilars were introduced compared to now. even before somebody does a biosimilar switch, you should objectively assess disease activity, because sometimes that class of drugs, it was only a matter of time that that drug, you developed antibodies and lost response to that drug. So sometimes it was the timing in which it appeared to be that it was the biosimilar, but it wasn't. I'm not saying for every case, but sometimes it was the case that that drug was already at its end of its useful span, and it just coincided with the time of the switch. So please, again, we are open to questions. Please see your physicians about this.
I think we covered this. A person in their early 20s in remission and would like to have kids. So we will post the recordings if you want to go back and check this out. Again, we covered this, the chart. Again, we can also cover this. You can go back and watch the videos if you're interested. This is interesting. Maybe how does IVF treatment, hormone injections, affect IBD symptoms? So it's the other way. Instead of how does IBD affect IVF, how does IVF affect IBD?
I think so for some patients, individual case by case, the hormone treatment sometimes can cause GI symptoms. I would say, like not necessarily causing an IBD flare up, but because of the hormones, maybe they might have some constipation or maybe they'll have diarrhea. What I've seen sometimes, though, what I think is some patients undergo IVF, but they didn't see their GI or didn't come. If they're my patient, they may not have told me, and I feel bad. I was like, oh, they didn't tell me, and their disease wasn't under control, and they've been trying the IVF, and then, when you look back at it, it may have been that it's not the IVF that caused the flare up. It's like they were already having a mild active disease. So that's what I've seen. But,
that makes sense. Thank you. Okay, what considerations are important for individuals with UC and a stoma to maximize their chances for a healthy pregnancy and delivery?
So as Vivian discussed before about the internal J pouch, this question is about having an external stoma or a bag. You can absolutely have a successful pregnancy and continue that pregnancy to term if you have a stoma. Most of the questions are what Vivian was answering before, that is, if there's been extensive pelvic, especially surgery around that time, there can be adhesions. I always say it's just like cling wrap. The more that you interfere with the area, the more cling wrap there will be, and you know that the eggs have to, transfer over. So sometimes that transport is not quite occurring as well as it can be, and that's why sometimes there needs to be implantation into the uterus. And again, assisted reproductive therapies work well. But specific to the stoma, there is not an increased risk of necessarily of obstruction. The bowel is floppy. We all know that. It will move out of the way generally. And the baby is, they're rascals, as we said before, but they don't generally, stick their foot right into the stoma or cause obstructions or anything like that. Some women will notice a bit of a change in the frequency or the volume of the output because of hormonal changes, but there is not an increased risk of obstructing the stoma. Some people, because of the increased pressure, however, will get more prolapse, so the stoma will stick out a little bit more. Work with your enterostomal therapist with this, because they have all sorts of devices, appliances, flanges, things to help, and certain things that even putting on like a little bit of, pressure around the other area, like a kind of a body belt. Many people use those kind of body belts for their back pain, things like that. There are modifications that can be considered in people with a stoma. So a stoma, in other words, is not a reason that you cannot pursue a pregnancy. I hope that answers that.
Yes, that was great. Thank you. Okay, so we do have some questions in the Q&A. Maybe I will pick two and then we can answer those if they weren't answered. And okay, so one question is, does formula increase the risk of Crohn's in babies, especially if they have a mom who has IBD?
I'm gonna leave that for Cynthia. I don't think there's enough.
I think there's a lot of environmental factors that we don't understand. Our role, I think, as moms is providing nutrition for babies. whether that is breast milk or formula. As I said before, people have their own personal decisions about which way they want to feed. I think it's really important here that we do not put the guilt on the mum. The mum is there to nurture in all sense of the way. I do not think that there is a specific environmental agent that increases the risk of developing Crohn's, with very few exceptions. And let me go through those quickly. Smoking. Smoking in the mum, as Vivian said, is a risk factor for developing Crohn's. Using antibiotics just for the sake of it, antibiotics treat bacterial infection. They don't treat viral infections. If you are on antibiotics during pregnancy or breastfeeding, it may change the microbes that are in the gut. And that is why, again, we bring it back to how can we prevent infections from occurring in the first place. So it doesn't mean that if you are on antibiotics that your child will get it. It is true that if you have an infection, anything that stimulates the system, active IBD, active infection, all of those can lead to bad outcomes for the baby. So it should be treated appropriately. What we're talking about here is that if you don't have an infection, of course, you won't go on antibiotics. Use these things judiciously to control active infection or active inflammation. And, don't be popping things that you don't need to pop, I guess, is the other way of saying it.
Thank you. And then the last question is that we're taking for tonight, since we're slightly over time, is how does postpartum affect moms with Crohn's disease? Are there noticeable differences in the healing after?
That question could be taken many different ways. I think, generally speaking, if the mother has been in remission and is staying on the medications that's required, then generally they should be okay. What we do see sometimes is there is a little bit risk of flaring postpartum, but as Cynthia mentioned earlier, we see that mostly in someone who's stopped their medications, and that's the issue there. So, and I think the only other thing specific to Crohn's perhaps is if someone did have a vaginal delivery but they had active perineal disease, that does happen sometimes, either personal choice or with the obstetrician, may have a little bit more flare of the Crohn's perianally. I think those are the two things that I would say.
Perfect. Thank you so much, Vivian and Cynthia. That wraps up the Q&A portion. Just a few quick points before we wrap up for tonight. If you have any further questions, please send us an email at learn@crohnsandcolitis.ca. Happy to help you through our inbox. Next, you will be receiving a very quick survey about the session today, about GLS webinars in general and how we can improve. We also use this feedback to come up with the topics for next year. So any insight you may have as individuals with lived experience, I really appreciate it. So please take some time to share your thoughts and feedback in the survey. Lastly, you can follow us on all these different social platforms at Get Gutsy Canada. So that's it for tonight. Again, a huge thank you to all our speakers tonight. So that's Laura, Vivian, and Cynthia, and also to our live interpreters. We're very grateful for them for helping us provide the session both in English and in French. And yes, thank you, everyone. Have a wonderful night and see you at the next Gutsy Learning Series. Good night.
Thank you again for the opportunity.
Of course. Thank you so much.
Good night.
Take care. Good night. Good night. Thank you.